Okay, let's pick up from where we stopped. We were talking about intrauterine growth retardation, and we said that some of the complications of intrauterine growth retardation is intrauterine fetal death. But even intrauterine fetal death can occur even without intrauterine growth retardation. So when we talk of death, all of you know death. It means that all the main organs are down. They are not working and a person is considered dead. So at the same time, the fetus can also die intrauterine. But here we have to be specific of the term of intrauterine growth retarded death, which means death after 28 weeks of gestation. If it occurs below 28 weeks of gestation, that can be called something else. Preferably, it will be considered as an abortion. But after 28 weeks of gestation, we think that this fetus is viable. But if this fetus loses viability, then it is dead. Or any time after 28 weeks of gestation, but before labor. Then this baby, after being born, it will be called a stillbirth. It will be a stillbirth. So when we say stillborn babies, this is a baby born after 28 weeks of gestation and has not at any one time after being completely expelled from its mother breathed or shown any sign of life. It may be a fresh or a macerated. Here we are looking at this. Let us be critical. I may deliver a baby who is severely asphyxiated, and this baby scores 1 or 2. And when I fail to resuscitate this baby, or when this baby does not come back to life, that baby is not a stillbirth. That is called a neonatal death. But for us to consider a stillbirth, this baby must have shown no any sign of life. That at birth the APGAR score was 0 out of 10. And this baby who is born dead before delivery should have been an Iufd, intrauterine fetal death. So the death may occur due to various reasons, as we shall see, but when we listen to the fetal heart, and there is nothing like any fetal heart, we move from fetal distress. Fetal distress means there is something like a fetal heart. So the baby is distressed, either below 100 or above 160. That is a sign of life. So that is fetal distress. But we can listen to this fetal heart and nothing we can hear. Neither so low, neither so high, but it is on 0. And as we use all other methods like Doppler, like ultrasound, there is no heart activity. So that is called an Iufd, intrauterine fetal death. And if this baby is born, so this baby is termed as a stillbirth. So we have said that this stillbirth can be fresh or macerated. When we say fresh, it means the baby may have died intrauterine, just maybe during the process of labor or just before labor, and the skin is, when this baby is born, the skin is very normal. That is called a fresh stillbirth. But at one time, this baby might have died some time back, and the body is peeled off, like somebody who drowned in water and died in water. And then for some time they get the body. The body is macerated. So that is the difference we should note when we are talking about Iufd. So here is the explanation that fresh stillbirth when the baby is dead a short while ago, and usually this occurs during labor, the skin is intact and no discoloration. But for emascerated, the baby has been dead for more than 12 hours, so the skin may not be intact. What are the causes? Let us look at maternal causes. We can look at all the causes that brought about IUFD. IU, growth retardation, intrauterine growth retardation, like hypertension, diabetes, connective tissue disorders, syphilis. All of these, they denied the placenta to function so well. So maybe the severity was so high that the babies even died intrauterine. When you come to fetal causes, we have the malformation, the infection, the hemolytic diseases, the metabolic diseases, the rhesus incompatibility, and others. So this can be brought about the fetus themselves when the fetus is structurally, or we have chromosomal abnormalities. When we have very severe congenital abnormalities, this baby may choose to die intrauterine. Infection, like we've said, bacterial infections, viral infection like syphilis, bacteria like congenital toxoplasmosis, malarias, etc. They can lead to death of this baby intrauterine. When we say immune hemolytic diseases, these are diseases which cause the red blood cells of the baby to break down. Preferably, this is very common in mothers who are having rhesus incompatibility, like in blood group O negative, maternal blood group O negative. This rhesus incompatibility or rhesus may bring about the breakdown of the red blood cells of the baby intrauterine, and the babies may die intrauterine. Then metabolic diseases, when there is a problem with metabolism and the baby is not getting sufficient feeds, rhesus incompatibilities, and others. We have continued to say for placental dysfunction, when the placenta is sick or infected, placenta previa, when the placenta is not perfusing so well. We can have twin-to-twin blood transfusion. When these babies are two, one baby can decide to transfuse the other, and at the end of the day, the one who is denied blood may die. Then we can have fetal maternal hemorrhages. When the baby may bleed, it may be an accident, and the babies are bleeding intrauterine, so this can cause the baby to die. Then when we look at cord conditions, there is what we call a cord knot, like a cord can loop into itself and we get what we call a true knot. It means there is a cut of oxygen completely to this baby, and this baby may die. Then when we look at prolapse of the cord, when the cord comes before the presenting part and goes out of the cervical os, this cord may be compressed and there is no oxygen. Then when we talk of strangulation is when we can have the cords going around the baby's neck. It may be more than one time, and it's like we are strangulating the baby, and this baby can die intrauterine. So there might be other causes which are related to labor which may lead the baby to die. And these are prolonged labor. When we talk of prolonged labor, we know that prime gravidas don't spend more than 18 hours in labor, and multigravidas don't spend more than 14 hours in labor. So when labor is prolonged, it can also cause anything like intrauterine fetal death. Obstructed labor, ruptured uterus, breech delivery, all these can be conditions related to labor which can lead a baby to die intrauterine when not well assessed or monitored. So diagnosis, how would we know that the baby is not breathing? Assume this mother is just coming in. Of course, for all mothers, we start with the history. And this mother will report no fetal movements. And when the mother reports no fetal movements, please, let's just not take it for granted. It might be true that the baby is not moving. And on history, this mother may present with predisposing diseases like hypertension, syphilis, malaria, etc. So on history taking, we can get that. So on examination, of course, the first thing, there might be a small foldate uterus. What should I say? Like if the baby died some time back, it means the baby decided to shrink and go down. So the abdomen on fundal height examination, it will be less than the dates of amenorrhea. For example, this mother may have been reporting that my pregnancy is 8 months, but on examination, when you do the fundal height can be really somehow lower than 8 months. So on auscultation, we shall have no fetal heart, and on observation, there will be no fetal movement. So we shall go ahead to do vaginal examination, and on vaginal examination, we can get a brownish vaginal discharge. So when we do that, we may query and take this mother for lab investigations. Of course, the mother will be HCG positive, meaning she is pregnant, which may be different if the mother is having fibroids. So the ultrasound will confirm the diagnosis when it tells us that there is no fetal heart activity. And then there shall be a collapse of the fetal body and overlapping of the intercranial bones. So as the baby dies intrauterine, the body will collapse and the intercranial bones will also shrink and overlap each other. They are saying abdominal X-ray, sometimes it is rarely used. These days we basically use the ultrasound scan, and if it is done, there will be gas in the cardiovascular system when this baby has died 3 to 4 days. Again, we shall get overlapping of the fetal skull bone. This is called a Spaulding sign. Due to liquefaction of the bones will start dissolving because they are still so immature. So they will overlap, and it is called a Spaulding sign. Then there will be marked curvature or undulation of the spine. We look at the fetal spine. Instead of it being strong and continuous, it will look macerated, and the spinous ligament will look what can I use? Wasted. They will look wasted. So when we do amniocentesis, it is rarely indicated, but sometimes if it is done, they take a sample of the amniotic fluid from the mother. It will show a dark brown turbid fluid with marked elevation of creatinine, phosphokinase. When they take off a sample of amniotic fluid on visual inspection, it will be brown and it will be turbid. There shall be some crystals in it. And when they do the chemistry, it will have creatinine, phosphokinase. Then when we do the routine laboratory evaluation on the mother, when we take up blood from the mother, we shall have platelet count and fibrogen and anticoagulants. So we shall do a platelet count and we shall also find out whether what is the anticoagulant, what is the time for clotting of the maternal blood. And we can also do what we call the indirect Kumbu's test, because we said that some of the cause may be rhesus incompatibility. So we take off blood to see whether this mother has immunized, if the mother was rhesus negative. So there is what we call rhesus iso immunization. When the Kumbu's test is positive, it means the mother has immunized. Immunized meaning her blood is already having antibodies against the rhesus positive antigen. Therefore, this mother, the blood is ready to fight any antibody, any antigen which is rhesus positive. Then we have the fetal karyotype. We also can take off the blood of the fetus and we see its karyotype. Then polymerase chain reaction of the fetal tissue to exclude fetal infection, amniotic fluid culture for cytomegalovirus and anaerobic and aerobic bacteria. So here we are just finding out what is the exact cause maybe of fetal death. Is it the cytomegalovirus, like we talk of the toxoplasmosis and others. Then this mother should be admitted on the ward, and we do what we call fibrogen measures and platelet count if fetal death is more than 4 weeks. For this mother, we wouldn't like to scissor this mother, because this mother will, first of all, is psychologically disturbed. Her baby, we have told her her baby is dead intrauterine, so the mother will be worried. Therefore, if we take this mother to theater, we are also incurring a problem of the cesarean scar to her. So it's better that this mother goes into normal labor. So, but before we do it, we measure the fibrinogen, and platelet count to see that whether this maternal blood can be able to clot. And if not able to clot, we give the drugs early. So the mother with signs of Iufd must be referred to hospital. So don't ever manage this mother in a maternity center because of the problems which may occur. Then, if stillbirth is delivered in the maternity center, examine the baby for abnormalities, not the sex and weight. Sometimes you never know, this mother may come in labor in the maternity center fully dilated. So what do? And you deliver the baby. You know that the baby is dead. So take the weight, take the sex, do the last office and everything, and manage the mother subsequently. And then complete a notification form and send to the DHO office. So this is, I think, a notifiable condition whereby you have to notify the authorities. Give support and comfort to the mother and family in their grief. You are soon going to do palliative care, but before even you do it, you have to learn how to give comfort and support to such patients. You never know it was their precious baby. You never know it was their first baby. You never know it was their only baby girl or only baby boy. So they need to be comforted. Yes, but if you send this baby to hospital and fetal demise means fetal death occurred before 13 weeks, like the baby died before 13 weeks, we shall call that a missed abortion. And this missed abortion can be managed by dilatation and curettage. If it is after 13 to 28 weeks, we have two different approach. One is expectant management. In expectant management, we expect this mother to go into labor and then push this baby. And we are saying at about 80% of patients, they will experience spontaneous onset of labor within 2 to 3 weeks after the baby has died. So this mother is going to go into normal labor and managed like any other mother in labor. The remaining patients not delivered spontaneously, we can deliver them by induction. So if this mother does not go into spontaneous labor, the next option is to induce them, not running to theater. So on induction, of course, we carry out all the process of induction of labor. Why? We are saying the justification of this. Why should we go into induction of labor? To avoid the emotional burden on the mother of carrying the dead fetus. This mother is already knowing that I'm carrying a dead fetus, and you wouldn't like this mother to go to theater. So we induce this mother, if this mother has not gone into labor, such that he expels the fetus. There is 10% of DIC. DIC means disseminated intravesicular coagulation. If the fetus remained for 5 weeks. What does it mean? That these mothers with intrauterine fetal death, they can have a problem which is called DIC, and this is an emergency. We are saying it is called disseminated intravesicular coagulation, means that the blood is not clotting. So this mother may bleed up to death. Now, if you take this mother to theater, this mother may bleed on the theater table and die. But because we are going to induce this mother, we shall be able to monitor and do the interventions as quickly as possible. So, for Iufd, these mothers may really bleed. Then another justification is there are a lot of chances of intrauterine infection. And this mother can go into septicemia. So induction is carried by prostaglandin E2. Remember we did the pharmacology of oxytocics, and under them we had prostaglandins. So we shall use prostaglandins E2 suppositories if the cervix is unfavorable, meaning that if the cervix is not well dilated, we shall have the prostaglandins and insert them in the rectum. And when we insert them, they will work on the cervix, and the cervix will dilate slowly by slowly, and then we shall put up an oxytocic infusion to increase if the cervix is favorable. What does it mean? If the cervix has started to dilate, we shall put up oxytocic infusion for this mother to get contractions, and maybe if done well successfully, this mother will push this dead fetus. So if the intrauterine fetal death is occurring after 28 weeks of gestation, the cervix is favorable for induction, just put up oxytocin. What does it mean? After 28 weeks of gestation, the mother has come on vaginal examination, the cervix is past 4 centimeters. We just put up a drip, and this mother will get contractions and will push this baby. But if the cervix is not favorable, we shall use the prostaglandins E suppositories. At this gestation age associated with risk of uterine rupture, Remember, these are prostaglandins. Their effects are non-reversible. So if managed poorly, we can even end up with a uterine rupture. So we must use very small doses, and we should be monitoring these mothers closely to look at the way they contract. So if the cervix is unfavorable, sometimes we can use misoprostol, which is placed in the cervical canal to enhance ripening, followed by serial daily oxytocin infusion. Misoprostol is also a prostaglandin now on market, so the doctor can decide to use misoprostol, and then the cervix ripens. Ripens means it becomes soft and thin, which will be easier for it to start dilating. And if it starts dilating, we shall put up oxytocin infusion. And then our next worry is the coagulation, which is a very, very, very deadly emergency if the mother gets DIC. So we should be able to monitor the coagulopathy. So monitoring expectant mothers is bi-weekly fibrinogen, platelet, and hematocrit examination. Fibrinogen is the power to clot, of the blood to clot. Platelets and hematocrit, we look at how many platelets does this mother have. Hematocrit, how is the anemia for this mother? Otherwise, this mother might bleed and even die. If we have any abnormality, further assessment is by prolonged prothrombin, partial thromboplastin time, and increased fibrinogen-fibrin degradation product. Remember, fibrinogen helps in blood coagulation. So if we find abnormalities in blood, that this maternal blood is lacking clotting factors, so it's better we give the prothrombin to help take the fibrin be converted to fibrinogen, ready for helping us clot. Yes. So we may give these products to the mother. And if there is mild DNC with absence of bleeding, delivery is indicated. If after our test the bleeding factors are okay, we may go in for delivery. And we are saying if severe DNC is noted or evidence of bleeding, then correction of defect by cryoprecipitate and fresh frozen plasma prior to intervention. All these blood products should be in the hospital before we begin the procedure to induce a mother with intrauterine fetal death, because we anticipate that this mother might bleed, might go into DNC when the clotting factor is already down. So we must be ready with the fresh frozen plasma of her blood group in order to help this mother survive. Otherwise, if we don't so, we may lose this mother in the struggle of delivering even a dead baby. So before we do that, we must do all the tests, the bleeding and clotting time, the hematocrit levels. We do the blood group and cross-matching. They should be available. Units of blood should be there. Monitoring should be very sensitive to the mother after delivery and even during labor, such that we don't also lose the mother. So with those few remarks, I think we can call it a day. Good day.